Good afternoon, everyone. My name is Carrie Farmer, and I am the co-director of the Rand Epstein Family Veterans Policy Research Institute. I want to welcome everyone to this webinar today. This is part of our bi-monthly webinar series focused on high-priority veterans policy issues. Okay, the next slide. Our Veterans Policy Institute has as its mission to conduct innovative, interdisciplinary research to improve the lives of those who have served in the U.S. military. We aim to publish and widely disseminate our research findings to connect objective and rigorous analysis to decision makers so that we can improve evidence-based decision-making. So this webinar is part of our dissemination efforts. A couple of quick housekeeping items before we get started. We have the chat feature open, so please feel free to ask questions or share resources that the audience may be interested in. If you'd like to ask questions to the panelists, please use the Q&A feature, which is also open. We will monitor that and we'll try to get to as many questions as we can. Next slide. Today, I'm pleased to introduce my colleague, Erin Taylor, who will provide a brief presentation of the findings and recommendations from her recent publication on veteran access to multiple forms of healthcare coverage. And we'll put the link to that publication in the chat. Erin's presentation will be followed by a panel discussion with our guest experts, Erin Fuse-Brown from the Brown University School of Public Health and Micah Hager from WellCare. I will monitor the panel and I'm looking forward to a great discussion. But first, I'd like to introduce Erin Taylor, who's a senior economist at Rand, specializing in healthcare insurance, prescription drugs, and care quality. She currently co-directs evaluations of Medicare models and leads research on the early impacts of the Inflation Reduction Act's Medicare drug provisions. She holds a PhD in health economics from the University of Pennsylvania and previously worked at the Centers for Medicare and Medicaid Services. And with that, I'll turn it over to Erin.
Great. Thanks so much, Carrie. I'm really excited to be here today to talk about health insurance coverage for veterans who are enrolled with the Veterans Health Administration, or VHA, and to participate in what I'm sure will be a really insightful panel discussion. So today we're going to focus much of the discussion on those veterans who are ages 65 and over and therefore eligible for Medicare, but I'm going to touch on some other forms of insurance coverage as well as part of this brief introduction. Next slide, please. So to dive right in 2023, there were more than 8.2 million veterans enrolled with the VHA. Next slide, please. Veterans enrolled with the VHA can receive care at VHA facilities and may also be able to receive care paid for by the VHA, but received at a non-VHA provider, which is also called community care. Next slide, please. Veterans are not automatically eligible for the VHA and must apply to receive these benefits. Eligibility is based on a veteran's length of military service, whether they have a health condition related to that military service, their income, and other factors. When veterans are enrolled with the VHA, they're placed into one of 8 priority groups, which determine how much they pay out of pocket for VHA services. Once enrolled, they don't need to reapply to the VHA every year, but the number of veterans that may receive services in a given year depends on the budget authorized by Congress for that year. While to date, the VHA has not limited the provision of services to priority groups, this structure allows the VA secretary service-connected or a non-service-connected condition. In 2025, VHA enrollees in all priority groups paid no copays for primary care and specialist visits related to service-connected conditions. But those in groups 7 and 8 pay $15 for primary care and $50 for specialist visits for non-service connected conditions. Veterans who are enrolled with the VHA may also have health insurance coverage from other sources, including Medicare, which provides coverage to eligible U.S. residents ages 65 and over and those with a disability. Those choosing Medicare receive coverage either via traditional Medicare, which is run by the government, or from a Medicare Advantage, or MA plan, which are plans run by private insurance companies that offer the same coverage as traditional Medicare and also may offer supplemental benefits not covered by Medicare. Veterans eligible for Medicare may also enroll in a Medicare Part D plan, which offers coverage for prescription drugs dispensed at retail or mail order pharmacies. Finally, veterans enrolled in traditional Medicare may choose to fill in the so-called gaps in coverage, for example, their deductibles and cost sharing, by enrolling in a Medigap plan run by a private insurance company. Veterans may also be eligible for state Medicaid programs, receive TRICARE for life benefits based on their previous military service, or have private insurance due to employment or from the Affordable Care Act marketplaces. However, we're not focusing on these other types of insurance coverage for the purposes of today's webinar. Next slide, please. So in 2023, about 84% of the more than 8 million veterans enrolled with the VHA were enrolled in one or more other insurance coverages. The largest share of these, the 8 million, so slightly more than 50%, were enrolled in Medicare, with most of those enrollees choosing to receive coverage from traditional Medicare. About 13% chose Part D coverage, excuse me, and 13% were in a Medigap plan in addition to traditional Medicare. Next slide, please. So why do veterans choose to enroll in health insurance? There are 4 main reasons that we've identified, including first, enrollment with health insurance gives veterans more choice in where they can seek care, including from private providers. Second, health insurance enrollment enables them to maintain access to care and have it be covered in the hopefully unlikely but not zero chance that the VA limits access to services for budgetary reasons. Third, health insurance may provide coverage for family members since the VHA does not cover those family members, though this is not necessarily the case with Medicare either. And then finally, enrollment in Medicare enables the veteran to avoid penalties if they enroll in Medicare Part B at a later date. And it also ensures no delays in accessing care if they do change their minds and want to enroll in Part B. Next slide, please. Although VHA enrollees do not pay a monthly premium for being enrolled in VA's healthcare system, veterans with other sources of coverage may pay monthly premiums along with deductibles and cost sharing when they seek care. This is generally true of all of the health insurance options shown on this slide, though Medicaid enrollees may be exempt from these costs depending on their income and state of residence. Next slide, please. So most veterans enrolled with the VA have other coverage, and they have the ability to choose where to seek care and which entity pays for the care. And they may incur additional costs for having insurance coverage. However, it's important to note that the VHA does not generally interact with other payers. This is because the VHA is a healthcare system that provides services directly to enrolled veterans, and in some cases pays providers directly for care provided in the community. As a result, while health insurance options can act as primary and secondary payers to each other, the VHA is generally siloed and in most cases does not ask insurers to pay for or request payments for healthcare services rendered. To focus in on traditional Medicare and MA here, VHA enrollees with Medicare coverage who seek care either do so within VA facilities or via VA-covered community care paid for by the VA, or they seek care with private providers that will bill TM or the patient's MA plan for covered services. Neither the VHA nor Medicare acts as secondary coverage for the other. In other words, the program that is not paying for care provided will not step in after the primary payer has paid to cover any remaining charges or cost sharing owed by the veteran. However, I do want to note that private health insurance coverage, including Medigap and employer coverage, is different. VHA asks that enrollees with private health insurance submit information about that coverage so that VHA may bill the insurers for care provided at VA facilities for non-service related conditions. Next slide, please. Given the lack of interaction between the VHA and government insurance coverage, certain types of insurance may result in payments being made for health coverage even if a VA enrollee does not receive care covered by the insurance. While traditional Medicare only pays for services rendered on a fee-for-service basis, The government, in the form of the Department of Health and Human Services, pays MA plans a monthly subsidy for the coverage of their enrollees, including veterans who may or may not use care covered by the MA plan. The same is true for Medicare Part D, whereby the plan receives a monthly payment for enrollees regardless as to whether they fill prescription drugs covered by the Part D plan. Next slide, please. So to bring it all together, there are risks of duplicative payments by both veterans and payers in the event a veteran is enrolled with the VHA and has health insurance coverage, where the coverage the veteran receives from the insurance program might be considered duplicative of what they receive from the VHA. Veterans not using care covered by the other insurance may incur duplicative payments for premiums in traditional Medicare and in MA if there's a non-zero premium for enrolling in that plan, as well as for Part D and private insurance. Payers, on the other hand, incur duplicative payments if they pay a monthly subsidy for the cost of coverage, regardless as to whether the patient uses any care covered by the plan. This is the case for MA and Part D, but not for traditional Medicare, where payments are generally only made when the patient seeks care. Next slide, please. So to close out the background part of this webinar, I'll just close with some directions for future policy and research. So first, the VHA could consider gathering enrollment and claims data from all payers to create combined data sets that track service use and payments for veterans with multiple types of coverage. Next slide, please. Second, the VHA could use the newly collected data from across the range of payers to estimate costs for payers and veterans with multiple coverage types and analyze how different coverage and payment options might affect them. Next slide, please. And then finally, the VHA could gather expert input on policy options to address multiple payments while maintaining access to coverage for veterans. Next slide, please. And with that, I'll turn it back to Carrie to moderate the discussion portion of the webinar. Thanks very much, everybody.
Great, thanks so much, Erin. That was a great overview of some of these policy issues. So we're going to jump into our panel discussion. I'll briefly introduce our panelists, but wanted to remind the audience to, if you have questions, please submit them using the Q&A feature, and we'll jump in. So first, just briefly introduce Erin Brown, who's a legal scholar and professor at the Brown University School of Public Health. She is an expert on Medicare Advantage and has thought a lot about how to improve it. Micah Hager is the Director of Business Development at WellCare and is also an active member of the American Legion in Texas. So welcome, Erin and Micah, and also other Erin, for joining us on this discussion today. So I'm going to start off with a question for Erin FB. So you've studied Medicare Advantage quite a bit. How would you characterize the policy issues at stake here?
Yeah, thank you so much. It's delightful to be here. And on the question of how the Veterans Health Administration coverage intersects with the Medicare Advantage program, Erin Taylor's presentation did a great job of just sort of illustrating the complex dynamics at play. So just to kind of dig a little deeper, Medicare Advantage pays the private health insurance plans, a fixed payment per enrollee. So they pay that amount whether or not the enrollee uses any services. This is called a capitated payment. And so there arises a double payment issue when a veteran is dually covered by both VHA coverage and by an MA plan. So in this case, the federal government is going to pay the MA plan, the Medicare Advantage plan, the full capitated rate, even though the Veterans Health Administration is also responsible for paying for the veterans' care through the VHA program. So unlike commercial health insurance or private health insurance plans, the VHA cannot seek reimbursement for care provided to a veteran who has dual coverage by the Medicare Advantage program. And the reason for that is through a quirk of the federal laws. So there's a statutory provision in both the Medicare statute and in the VA statute that prohibits the VA from seeking reimbursement from the Medicare program for this situation of someone who is getting care who is covered in both programs. And the reason for that probably is because traditional Medicare, you don't have this dual payment problem. And because fee-for-service, again, won't pay for services that are not, unless they're paid for by or rendered by a Medicare provider, that this double payment issue simply doesn't come up. However, Medicare Advantage has been growing in popularity as among Medicare beneficiaries and among veterans who are Medicare eligible. So now Medicare Advantage is the coverage of choice for more than half of all Medicare beneficiaries. So that means that this dual payment problem is growing in size. My colleagues here at Brown, led by David Myers, estimated that the total annual costs that the Veterans Health Administration paid for services that could have been, if there wasn't this sort of statutory block on reimbursement, that have been also doubly paid by the Medicare program, as about $12.1 billion in 2020. And over a decade, the total amount that VHA cumulatively paid for veterans, for dually enrolled veterans, was $78 billion. So that's their estimate. So what are the policy options to address this? There is currently an introduced piece of legislation in both the House and the Senate, and I can drop a link to that in the chat once I'm done. And it's called the GUARD Act, and the GUARD Act was introduced, the primary sponsor in the House with Lloyd Doggett, Representative Doggett, and then there's a companion parallel bill in the Senate. And the GUARD Act would basically allow the Veterans Health Administration to seek recoupment from the Medicare Advantage plan the same way it does for commercial or private health insurance plans, and to sort of take away that statutory prohibition from seeking recoupment when a veteran who is eligible for both or duly enrolled in both receives care that is paid for by the Veterans Health Administration. And my team, again, the economists on my team estimated that taxpayers and the Veterans Health Administration could save an estimated $357 billion over the next decade were this recoupment to be permitted, just in terms of eliminating this double payment problem. So I'm going to stop there, but I'm happy, again, I'll drop a link to the piece of legislation in the chat.
Thanks, Erin. And so we might think, and someone asked a question about this, well, maybe the solution then is just to stick with traditional Medicare, but I bet Micah has an answer for this. So Micah, can you share a little bit about your role with WellCare and your perspective on veterans and Medicare Advantage, and what are the benefits for veterans of having a Medicare Advantage plan?
Yeah, thank you, Carrie. I'm Micah Hager with WellCare, Director of Business Development, and got a long history with Medicare, and really do focus a lot on helping veterans understand what their options are when it comes to senior health, Medicare Advantage being one of those. Some of the benefits of Medicare Advantage over just being on a regular VHA plan, or including TRICARE for Life, Champ VA, or just VA Health in itself, is the additional increased dental benefits. We hear a lot from veterans that sometimes they don't get the dental benefits that they need for their care through the VA or get dental at all. So having a dental benefit through the Medicare Advantage plan is is very helpful for them in that case. Increased vision coverage, increased hearing coverage, and sometimes there's even some emergency care coverage. That becomes very helpful. We have heard numerous times with our, interacting with a lot of veterans on some of the things where they have issues with the VA not covering a certain procedure, or covering a prescription drug that they need. Or I spoke to an individual that's from Florida, where she had knee surgery, and TRICARE for Life paid for the whole thing, but she had to get outpatient therapy, and TRICARE for Life did not pay for it. So she was left with a bill that she was not really expecting, and had to, do some research on how to get that reimbursed. And I understand that, we know that there's some communication issues between Medicare Advantage plans and the VHA or veteran healthcare plans. A lot of times with who's going to pay for what, who becomes primary, if there's a secondary, and how that all coordinates and collaborates alongside each other. We have seen a lot of times recently where if an individual has VA healthcare, that they are getting, and I know Aaron kind of mentioned that they don't work hand in hand, but we have seen it where the provider bills Medicare Advantage and has billed the VHA or TRICARE for Life or the VA plan or whatever other Champ VA, and they have been paying for the copays and out-of-pocket costs, which is, I know, kind of interesting, and where they say they don't communicate, but it is something that we have seen a couple of times and with people that have had both plans. Not saying that that happens all the time, because it's really, I think, selective from provider to provider, and not all providers will do that. So I do think that there's some opportunities where having a Medicare Advantage plan does benefit the veteran for some of those additional benefits that they don't get on original Medicare or through the VA. But I do also know from talking to a lot of people that there's still some misconceptions and some stigmas out there about who should get a Medicare Advantage plan. Should you enroll in Medicare, and why should they enroll in Medicare? And I think it's all about educating the veterans on what options are available, how the two plans work, and what additional benefits go inside with the Medicare plan. One of the bigger issues we still see with Medicare and the VA and CMS, or Centers for Medicare and Medicaid Services, is that VA healthcare is not recognized as credible coverage, which is unfortunate, because there's a lot of veterans that are older that never enrolled into a Medicare plan, Part B. And now if they were to enroll, they've been penalized because they were told, since they have VHA, that they never will need Medicare. Sometimes that works, but there's a lot of times where it doesn't. And as they get older, they need a Medicare, they need additional coverage, and are looking for Medicare. And now they're going to be paying a penalty. So, we think too, a lot of times, that the VA healthcare, VHA, should be recognized as credible coverage, just like any other healthcare out there. And I think that that's one of the things that frustrates some veterans too, is like, they're like, but I've had healthcare just like anybody else. Why am I being penalized now? And I think that that's something that needs to be recognized as well. So I'll end with that.
Yeah, that's helpful. I mean, that's like a whole nother layer. There's like these policy issues at the government level, right? Of like, are there duplicative payments, and as taxpayers, should we be concerned about this, and what are some of the policy issues to address it? But then there's also these concerns at the veteran level as well, of like, this is confusing, and what counts and what doesn't count, and do you need both, and in what situations? Never mind the complexities of traditional Medicare versus Medicare Advantage. It's a thorny topic. All right, so now, and I'm hoping we can dive into all of this, but I'm going to ask Erin T. a question about how do we think about balancing like wanting to ensure that veterans have choice and access to different providers and some of the other benefits from Medicare, with also ensuring the efficiency of the federal healthcare coverage. So this is sort of getting at these two levels, right? Like, how do we balance the benefits for veterans with the responsibility of having an efficient federal healthcare system?
Yeah, I think this is a great
Easy question to answer. So
exactly, it's a great question, Carrie. And like, I'll start to point at some pieces, and then I really look forward to further discussion with Aaron FB and then Micah too. I think this question really gets at the crux of the issue. So this is about establishing objectives related to ensuring that veterans have access to meaningful coverage for accessing their healthcare services, while also ensuring that payments by the government are efficient and not duplicative. I would suggest that a starting point in terms of an important objective is to ensure that veterans have access to comprehensive coverage for their healthcare needs. One way to achieve that objective is to say that VHA care should be provided at a level that veterans feel is sufficient and leaves no gaps. So to Micah's example of dental care, maybe VHA needs to revisit whether or not they cover dental and under what circumstances. If they do that, this might reduce or eliminate the feeling for veterans that they need another source of coverage because they perceive that there are these gaps with their VHA care. Of course, this raises important questions about how best to do this, and can the VHA do it within the budget that they have available on a given year and anticipate having in future years. So another way to get at this is to try to revisit policies that allow for these duplicative payments by the government and other payers, and redesign the way the systems interact, or don't in this case, and the case of MA in particular, so as to ensure that government dollars are spent in an efficient way. It could look like allowing a primary secondary type of payer relationship, similar to I think what Erin was highlighting that the GUARD Act seems to be starting to get at. It could look like adjusting payments to MA plans to account for dual receipt of VHA benefits, and so on. I think we could all probably come up with a number of other options, but I'll stop there and I look forward to further discussion.
Great. Thanks. So let's get into like the redesigning the system. I mean, Erin threw out a couple of ideas. Are these, what needs to happen to move some of these policy ideas forward and really think about redesigning the system? What are the barriers? And Erin, FB, maybe you've been hearing some of this as you've been following the legislation with the GUARD Act.
Yeah, so I think that, I think, again, this is, as I echo Erin Taylor's observation, that this is the crux of the issue. And also to keep in mind that they're not at odds. So in this case, providing and ensuring that veterans have access to comprehensive health coverage and healthcare services, in some ways goes hand in hand with the idea that the Veterans Health Administration's budget is finite and has to be stewarded responsibly. And so to the extent that this represents an area of potential ways to preserve or more efficiently use the budget that the VHA has to actually provide care, in terms of allowing it to seek repayment or reimbursement from the Medicare Advantage and Part D parts of Medicare, I think that in some ways would go further to extend the budget or extend the reach of the services it can provide. So in that sense, the version of the GUARD Act that was introduced by Representative Doggett and co-sponsors does sort of seek the recoupment version of the policy option, as there are a couple of different options. One is for the Veterans Health Administration to be able to seek repayment the way it does from the private health insurance companies for the care provided to dually enrolled Medicare Advantage veterans. So that is the policy path that's in that legislation. I think the reason, to the extent that we can tell, the reason that it chose that path as opposed to trying to somehow reduce the payment that the Medicare system is paying for Medicare Advantage enrollees, reducing that capitated or predetermined amount on the Medicare side, is it does sort of allow that money to flow. Again, it's all taxpayer dollars, but it does redound to the benefit of the VHA budget. And so I think that is one advantage. And then the other is it already builds on a system of recoupment, which I think anecdotally, is already in place for the commercial insurance market. And so to the extent that it is, known, maybe it's working not perfectly, but I understand it works fairly well. And so to the extent that this would just sort of expand that same recruitment mechanism to the Medicare Advantage market, that also is somewhat of an efficient choice. So those are, I think, the two considerations there.
Carrie, may I ask?
Yeah, please. Yeah, go ahead.
Question, or Erin, not to put you on the spot with it, but to make sure I understand what the GUARD Act is proposing to recoup. Is it recouping some portion of the cost of providing the service as a whole, or is it helping to fill in kind of the gaps in what the patients, the veterans, would have paid as part of their cost sharing? Or can you say a little bit more about that? I'm fascinated.
Yeah, so I think it would be the former, recouping the amount that the VHA has spent on providing these services or paying for community care services to veterans who are duly enrolled in Medicare Advantage. And because there's no, as you mentioned, there's no secondary payer or other interaction between the Medicare Advantage program and the Veterans Health Administration, the Medicare Advantage plan is receiving its full capitated payment because it's expected to cover those services. So to the extent that the VHA is covering those services, the GUARD Act would propose to allow the VHA to seek reimbursement for the cost of services provided to these dually enrolled beneficiaries.
Got it. Thank you for clarifying, and that's encouraging to hear that detail. But do you happen to know if they distinguish between the service-connected versus non-service-connected conditions, or is that kind of unclear in the?
I think it would be for those, and I don't know where this falls in terms of service connected versus non-service connected, for the services that the VHA would see itself as being responsible for covering. But I think that then there's the question of, like, you know, whether there's a distinction there. I haven't followed exactly that line of detail.
No, got it.
Great. And, you know, another issue from the veteran perspective is in like this coordination of care across health systems. And Micah, I don't know if this is something that when you're talking with veterans about their healthcare options, like how to think about, and we have a couple of good questions in the chat about, like, you know, should veterans also, you mentioned this briefly, like enroll in Medicare? You know, how do you think about this, and sort of what are the ways, you know, one thing that we think a lot about is in coordination of care and getting care from different health systems as well. So there's the, you know, that could also add additional inefficiencies.
Yeah, I think first and foremost, I'll say this, that anybody that turns 65 that automatically qualifies for Medicare, they're going to get Part A. They have to make the initiative to enroll in Part B. And we encourage and educate everybody that's turning 65 that they should enroll in Part B and Part D when they become eligible, because if they ever have to enroll in it down the road, there's a penalty until something changes where VA healthcare, VHA, is considered credible coverage. They should enroll in that Part B coverage. I'd be curious if Aaron knows if that RAND bill has, you know, if there's anything in there about recognizing VHA as credible coverage, because I think that that's an important piece for veterans. I think it's quite unfair that, you know, we'll recognize any other private health coverage out there. We'll recognize any other coverage, period, but we won't recognize VHA as credible coverage. And that's interesting to me. And I think it's very unfortunate. So I'd be curious, Aaron, if that is something, do you know if that's part of the RAND bill? I do know that there is some legislation out there about trying to incorporate VHA as credible coverage. I don't know where that's at, but I sure do think it should be at some point. And I'm curious if the RAND bill if the RAND bill addresses that in any way. If we know of that, I don't know.
Yeah, I don't know the specific answer to that question.
Okay.
I don't know either, but I want to take a moment, Micah. I think it's fascinating and a potential problem that Part B, as in boy, of Medicare doesn't count as creditable coverage. So they'd have to pay a penalty if they enroll later, and then they might have to have a waiting period before it would become effective. It is interesting to think in the context of MA, because generally to enroll in an MA plan, you do have to have Part B as in boy. So there would be some interesting interactions to think about there. You know, if the GUARD Act moves forward with the fact that to be enrolled in MA, you need to have Part B as in boy. I will say my memory and understanding, maybe you can confirm or correct, I think Part D as in dog has long been considered creditable coverage. For the VHA has been considered creditable for Part D, which at least helps somewhat there if veterans choose not to enroll in Part D when they first become eligible, but then later decide that they would prefer to have that as well.
Yes, Aaron, I 100% you are correct on that. Part D, if you have prescription drug coverage through the VHA, that is considerable credible coverage for Part D. Part B, unfortunately not. If you are eligible for TRICARE for life, so you're a TRICARE member and you go into TRICARE for life, you do have to have both Part A and Part B to be enrolled in TRICARE for life. You know, so that's, you know, they are told, yes, you need to enroll, make sure you do it. It's more about the ones that are like, that have a rating disability and just utilize a VHA. I spoke to a gentleman in Texas, and he was, I think, 40% rated and utilizes the VHA. He's 73 years old. He was told at some point, and I don't ever like to say that, but at some point he was told when he was going into the VA, since he was receiving his care through the Veteran Health Administration, through the VA, he doesn't need to enroll in Medicare. And so he never enrolled in the Part B plan. At age 73, he had some health issues with diabetes and such, and for whatever reason, he's not going to get coverage through the VA for it. Not sure why, don't understand all the circumstances, but now he doesn't have Part B coverage. And so he wants to enroll in it. Now he's got, 8 years of penalties. That's so unfortunate. And that's devastating for this individual that now needs some sort of Part Medicare coverage, whether it's original Medicare or if he wants to get it through Medicare Advantage or a Medicare supplement, it really doesn't matter. It's just that there's some education that we have to get better about educating our veterans that when they do become eligible to make sure they're getting all levels of Medicare at age 65, regardless of what healthcare. I do think that, Carrie, you talked about how plans coordinate and work alongside. We do see that these plans do coordinate in some cases, but it really does become more of an issue with the provider if they're willing to do a dual bill. Some providers will dual bill, some providers won't. And so it really is from A to B difference on what's going to happen in each individual case does vary. So when we're talking to veterans, one of the biggest things that we educate them on is that when they sit down to review their options, 1, check with your provider, see, is there an option for a dual bill? 2, see what services you need outside of the VA, if you need services outside the VA, and what are those additional benefits that you're looking for. And I think that that's important. Not, Medicare Advantage is not for everybody, and every Medicare Advantage plan is not for everybody. I know that, we know that, and so there's a lot of options, and it's all about educating our veterans and just the general public in general about what is available. I think Medicare in general, that Medicare, I always call it the Medicare maze, is one of the most confusing mazes to try to, maneuver through. And I don't think there's any real true right answer for any one person. There's so many different answers out there, and it's really all individualized.
Great. And somewhat related to this, and Aaron FB, from your colleagues' research, I don't know if you know this, but do we know about how many veterans or what proportion of veterans who have are enrolled in VHA and also have a Medicare Advantage plan don't use any Medicare Advantage services? If that sort of rolls up to $12 billion, that sounds like a lot of people, but I don't know if we know numbers about that.
Yeah, I don't know how many of them, in terms of the service breakdown. We do know that enrollment in general, this dual enrollment issue is growing. I'm trying to open up the numbers here. And so that's one of the reasons the costs are increasing year over year. But I don't remember if I have a record of what proportion is sort of like veterans who use no Medicare services and all VHA services, all the way down to veterans who use very little VHA services, but who are using a lot more Medicare services.
I think every veteran situation is unique. I think here we're sort of talking at the big picture policy issue. And I think we can think about Micah in particular. I think you might have, there are a couple questions in the chat sort of about individual circumstances, and there may be resources that that we can throw into the chat as well for individual veterans with questions about their own coverage. There's a couple of great questions here about the GUARD Act, and I wonder if one of you might have the answer. So if the GUARD Act goes through and the reimbursement or the recoupment is paid back to VA, will there be a chance that premiums charged by MA companies will then increase in response?
So the amount that the premiums that the Medicare Advantage plans charge to enrollees is really set through a complicated process, a bidding process that the MA plans use that isn't necessarily calibrated to whether or not it's someone has a VHA coverage or not. And so it's unlikely that the VHA plan, this VHA recoupment process will necessarily result in higher premiums. Currently, many Medicare Advantage plans charge only the sort of traditional Part B premium and a $0 additional premium. And so, I think that right now they're sort of able to do so in a way to kind of keep it competitive. And it seems unlikely that this would necessarily change the calculus, although it might change the degree to which Medicare Advantage plans sort of aggressively market to veterans because of this, because right now they're profiting off of this double payment issue. And so it might be an area that, again, doesn't mean that they'll be less available. It just might be less aggressively marketed to veterans if this ceases to become such a sort of profitable area for MA plans.
Carrie, could I follow up on and Erin, I'm curious about what you think about this too. I've kind of only dabbled in this particular nuance, but you mentioned the kind of focused marketing towards veterans by MA plans. It seems that there are some MA plans that are more targeted towards veterans and are kind of designed with them in mind for enrollment. Have you taken a look at any of those plans in particular? I think they have to still be open to general enrollment anyway, so I'm sure they're adhering to your general kind of pricing practices notion. But I'm just kind of curious if you think that there are certain subsets of plans that might be more affected.
Yeah, I think that I mean, it's hard to say exactly what the results would be, but I think that those plans that are designed to be marketed, again, with veterans in mind, they may, be less, there may be less of them, although there's still plenty of general Medicare Advantage plans available. So I think it's more that that's maybe where we might see some changes. It's not so much in the premium costs or the availability overall, but it maybe is these sort of like veteran specific plans. Again, this is just speculation, might become a little bit less common if the sort of revenue strategy changes.
Yeah, if you don't mind, I wanted to jump in on that. And yes, Erin, there are definitely plans out there that we do develop that are a focus for veterans. A lot of times the carriers will call them like Patriot plans or something along those lines. A lot of those plans too will not include the Part D plan. So it'll be just a Medicare Advantage only, and they won't include a Part D benefit on that, specifically maybe more so targeting those individuals that might be on TRICARE for life or getting their prescription drugs through the VA. So that's one aspect of it. The other aspect of it, these plans build in a higher benefit for the benefits or the services that they don't receive through the VA, which is like their dental benefits. So they'll put a higher limit of dental benefits that they can get on that. And then there might be some mental health coverage on there that they increase the mental health coverage, which we do see a lot of interest with veterans and nowadays with what veterans are going through. And then maybe like some additional vision coverage. Hearing, we will put it on there. Veterans tend to get pretty good hearing coverage through the VA, but sometimes they don't get enough coverage or maybe they want a different hearing aid than what the VA will provide them. So they do look for some of that. So that's kind of how they build these plans up. I don't know, to Erin's point, I don't know if, there would be less of a focus on veterans for Medicare if things change going forward. I still think unless the VA changes what the benefits that they're providing to veterans, that I think Medicare Advantage plans and these carriers are still going to put a focus on it because you're providing those additional benefits that they don't get from the VA. And that's really what's important about a when we sit down with veterans, we know they're getting good care, a lot of times at VAs. One of the issues we do hear a lot, I will say, is that the VA is so far away, right? So they got to travel hours, like 2 hours to get to the VA clinic or even an hour tends to be a long drive for them. So they ask, what kind of coverage or what kind of care can I get close to home? Again, a Medicare Advantage plan provides them those options. I know that the community care is an option for a lot of times for care out there too, but then they still feel they have to get to the Medicare or to the VA first, and so they look for, those are just some issues that tend to arise for individuals. Is, you know, that distance tends to be a lot, especially for veterans, right? Or and people that are older that can't drive. So transportation, it's a benefit that we provide on a lot of Medicare Advantage plans. They can use transportation to get to and from their appointments and such. I don't know if we'd ever stop focusing on veterans. I don't, in my personal opinion, don't think we would, because there's a lot of other benefits, unless they start building those into the VA, that Medicare Advantage plans do offer. And I think that that's what outweighs not doing it. So.
Great. All right, people are hot and heavy with the questions. I'm gonna quickly look at them. So there's a couple of questions about sort of like the decision to the point in time at which people become eligible for Medicare and are not enrolling in Medicare Part B because it is not affordable and not doing it for cost reasons. And sort of how, you know, I do think that there are, for some, you know, some Medicare Advantage plans, there's not a premium, but there's still the cost of Part B. And then this issue of, if you don't enroll and you find that you need it, if you don't enroll when you become eligible and you find you need it later on, what are the options for then enrolling after the fact? And one person gave an example of working with a veteran who's in his 80s and needs long-term care and yet never enrolled in Part B, and sort of is concerned about sort of starting that process now and there being a penalty to pay. You know, I think this sort of gets at sort of this overall picture of, this is all really complicated. It's like there's so many ways to get care, and there's so many hurdles, and there's a lot of confusion about it. You know, I don't know if you can answer any of these specific questions, but I wonder, from your research or your work with veterans, you know, this is the kind of thing that you hear frequently about these issues, both about the affordability and about the confusion about the process.
Yeah, if you don't mind, I'll jump in here real quick. Yeah, the Part B premium of $185, that gets to be a bit of a burdensome for veterans. As of the last few years, maybe Aaron, you can help correct me if I say this wrong. I think it's like last 3 to 5 years. Carriers started building in that benefit of the Part B give back. And so there are some options out there for veterans to enroll into plans that have a Part B give back. It doesn't provide the complete $185. It does vary from area to area, but there is some plans out there that do that helps alleviate that burden of the 185. So I would encourage people to look to see if some of those options are available. Now, I do know that that might be one of the first things that might change if, you know, the GARDA goes through, right? You know, Medicare plans are going to probably revisit what benefits and at what level of benefits that they provide, right? And I understand that, but right now that Part B give back is an option for veterans to help offset that cost. I would just encourage them to look out there. And that, I know there's, you know, every carrier has some sort of Part B give back at different levels. I will say that there's also, you know, another benefit that they build into some of these, and they call it the OTC card, which is like a spendable card, which help offsets some other costs that veterans will incur, which would be maybe like vitamins and Tylenol, pain relief, things like that, that they can use at different CVSs to help offset some of other costs that they might incur. And they can also use that to help cover some of the deductibles and co-pays for like their dentals and visions and such too. So there are ways out there that these carriers try to help offset some of those other burdens that veterans do receive when it comes to those additional costs with that Part B premium.
I might just add to that, Carrie, to the specific example from the person you highlighted, that it is worth double checking Medicare coverage to make sure that it would be worth enrolling so late and paying that penalty. Because it's given just the brief example, you know, unfortunately, Medicare doesn't really cover long-term care services. So if that's really what's needed for that individual, they might be better served by looking to see if they might be eligible for Medicaid in their area instead of enrolling in Part B and paying that kind of fairly high penalty. I can't, you know, obviously I can't say for any individual what's right, but just making sure that you review all of the coverage that would be available and then taking that into account and how much would have to be paid in the premium if they chose to enroll.
It gets at the question when we have one person who wrote in that these systems could not be more fragmented and complex, especially for seniors, often without computer skills or an understanding of the best options. Therefore, the mistakes made by thousands of seniors take time and money from all concerned, thus perpetuating the mounting costs and serious miseries. And I like this suggestion. Why not create an advocate corps for seniors 70 and over who desperately need this type of help? The cost would be paid for through savings generated from the mistakes. I don't know if I've ever heard that as suggested as a policy suggestion. I think it's terrific.
It's an excellent idea. I will note that certain types of these organizations exist at the local level. You know, the Centers for Medicare and Medicaid Services funds some of them. So state health insurance assistance program counselors who can help people navigate their different options, especially for Medicare. I have a kind of local senior center in my area where I live that I think every year gets geared up and helps people think through, you know, the complex choice between staying with their current MA and Part D plan or whether to enroll in another. And so, but further expanding that and helping people think even beyond just Medicare and with the interactions with VHA and others would be immensely helpful. I agree.
Do you think the GUARD Act makes things simpler at all for veterans? It might make things more efficient from the government perspective and you know, in reducing potential overspending. But does it improve? Does it have the potential to improve care for veterans?
I think it doesn't, it's not, really didn't set out to solve the problem that is being discussed now, which is the sort of complexity, the decision trees, the, you know, like how to navigate for the individual. What, you know, that probably wasn't the sort of the key issue here. The key issue was sort of like just dealing with the sort of like the budgetary, like where the money goes within the government, you know, which then again, like ends up showing up as costs to those who are involved. But I think for the most part, yeah, it's not designed to necessarily solve some of these other issues that folks are experiencing.
Are there policy options on the table that you all are aware of that might address this other sort of, you know, I think of it as like another source of inefficiency, right? Because it's sort of the cost to the veteran of navigating the system and the cost of making mistakes and signing up for care that's not needed or not at the right level of coverage. Are there policy options just, you know, that might on a bigger level solve some of these types of inefficiencies? I mean, short of starting from scratch and scrapping our entire healthcare system and doing it differently, yeah.
Gary, that's what I was going to, you know, you know, unfortunately, until unless we decide to go single payer or something and make it simpler for.
Oh, Erin, you froze right at that suggestion. Great. Well, we only have a couple of minutes left. I wonder if each of you want to give a last thought about this sort of complex and important and really interesting issue around trying to balance access and appropriate level of coverage for veterans with this need to be efficient and try to reduce spending and you know, potential overpayments. So let's go with Erin FB first.
Yeah, no, I mean, I think this was I learned a lot from this conversation, and I think that it's really important to kind of keep in mind that there's, yes, there's one problem with like government spending and overpayments and stewarding, scarce resources, but then to also recognize how the siloing or the fragmentation of all of these, we only talked about Medicare primarily today, and I know that Erin Taylor's document and perspective piece has a lot of other data. I mean, there's a lot of other dual enrollment, options, and veterans are facing lots of complicated doors that they can walk through. So I think anything that could streamline that or help navigate that complexity would be extremely useful.
Great, thanks. Erin T, last thoughts?
I think what Erin FB just said was wonderful, and I don't have much to add beyond that. I think, continuing to work on these issues and try to identify policy options that help all of the different stakeholders, both veterans in ensuring that they have meaningful access to care, and then trying to help the federal government manage its budget more broadly. So.
Great, and Micah?
Yeah, first, I did put a website in the chat, wellcareforveterans.com, where we do have some information, and we keep updating that with more information. And that's what, so, hopefully I'll be able to collaborate with Erin and Erin some more so we can continue to build on that. But I do want to say that as I've kind of been working with WellCare and our partnership with the American Legion, and really do focusing my time a lot with veterans, and being a veteran myself, being a member of the American Legion, my dad being a veteran, dealing with having VA healthcare and Medicare Advantage, and going through all of that back in Minnesota. I do still struggle that even as a country where we are today, where we still have an issue trying to provide a good quality care for our veterans, and we're still questioning, how do we do it? Like, I hope we continue to be able to find ways to build on that and provide services to our veterans, and help try to navigate this coordination of care between Medicare and the VHA, so that we make it easier for veterans and not make it more difficult. I think right now we make it more difficult. And I think that that's hard for veterans. It's not fair for what they've gone through. So I hope that, over time, we continue to work and make that an easier process.
Great, thanks. Thanks to each of you for participating in this webinar, and thanks to everyone who attended for your great discussion and questions. I really appreciate it. And again, the recording will be available. We'll send it out as soon as it's ready in about a week or so. So thanks a lot. All right, take care.